Good morning, everyone. My name is Julie Burns, and I'm the President and CEO of RIZE Massachusetts Foundation. I want to welcome you to Harm Reduction, Housing, Hope, the Keys to Low Threshold Housing. This is the second in a series of learning communities hosted by RIZE, the National Harm Reduction Coalition, and the Kraft Center for Community Health. Before we get started, I have a few announcements. All participants will be on mute throughout the program, and we're recording the webinar. Based on the incredible response we had to this event, we know that there is great interest in this topic. And after analyzing feedback from the previous event, it's clear that you wanted to hear about best practices and action steps that you can take in your own organizations. With that in mind, we'll start the program with a panel discussion focused on sharing best practices and addressing topics raised by audience members during a pre-event survey. Given the importance and timeliness of our subject matter, we've set aside plenty of time after the panel discussion for your questions. Please feel free to enter your questions throughout the program, and especially during the question and answer session, using the Q&A option on the toolbar. We also encourage you to use the chat as you are right now to introduce yourself and engage with your fellow audience members. We hope you'll engage with Twitterverse as well. We'll be live tweeting the event. Please join the conversation and follow us on Twitter. Our handles are @RIZEMass, @HarmReduction, and @CraftComHealth. And we'll be using the hashtags Keys to Housing, all one word, and Zero Stigma, Zero Deaths, all one word. Finally, you'll receive a survey at the conclusion of today's event. I hope you'll take a minute to fill it out and help us plan future programs. Now to get started, we have a number of new attendees joining us. Some of you are new to RIZE, so please allow me to give a brief overview. Launched in 2017, we are an independent nonprofit foundation created to end the overdose epidemic. We're made up of a constantly growing group of providers, payers, union advocates, and people with lived experience who are equity-minded, entrepreneurial, collaborative, and dogged in pursuit of our mission. We share and convey a sense of urgency that addressing the overdose crisis can't wait. One of our strategies to end the opioid crisis is to serve as a neutral convener. Bring people together, share learnings, support exploration, enable change. And that is our goal for today. Here in Boston, we're uniquely aware of how housing and treatment are co-equal components when engaging in recovery efforts. What we're finding is that they go hand in hand. Engaging in harm reduction while in stable, supportive housing can make the difference for so many people experiencing addiction. With these shared goals in mind, saving lives and keeping people housed, we need to ask questions like, what are the keys to low threshold housing? And how can harm reduction and housing providers partner to better serve people with substance use disorder? These questions will be the focus of today's learning community. I'm thrilled to be joined by Laura Guzman from the National Harm Reduction Coalition and the DOPE Project based in San Francisco, and Andrew Spiers from Pathways to Housing in Philadelphia, both nationally recognized leaders in harm reduction and housing. They'll share their insights focusing on person-centered approaches that build trust and autonomy with an emphasis on how to best support people who use drugs. We're also joined again by Emma Roberts and Sarah Gorey from the National Harm Reduction Coalition. Emma will serve as our moderator and Sarah will lead the Q&A. And we're grateful, as always, to partner on another convening with our close collaborators on harm reduction, the Kraft Center for Community Health. We'll hear from Dr. Elsie Tavares at the end, who will wrap things up with a few closing remarks. Our hope is that today's session will serve as the foundation for ongoing discussions, collaborations, and partnerships with the goal of keeping people safe, housed, and alive. As we've said before, if this topic continues to be of interest, we'll keep the convenings going. Before I hand things over to Emma and the panel, I'd like to thank everyone joining us today. We had over 300 people register from both the harm reduction and housing profession. That shows not just a willingness to understand, but a desire to create change. And that alone gives me hope. With all of you here seeking to change the status quo, we're going to find a better path forward. So thank you. Emma, I'll turn it over to you, and I look forward to today's presentations.
Thanks, Julie, for that great introduction. It's really good to be back. And for those of you that didn't meet me last time, my name is Emma Roberts. I'm the Senior Director of National Capacity Building at the National Harm Reduction Coalition. And I started out in harm reduction a long time ago in the mid-90s in the United Kingdom, when the community centre that I worked at was tasked with setting up a syringe service programme in the corner office of our community centre. And most recently, since coming to America, I've run a syringe service programme in New York, a mobile programme, and added mobile medical and dental and treatment services to that. And then I've been full-time at the National Harm Reduction Coalition, where I now help since 2014. And I now help work with the team to manage our national capacity building, training and technical assistance services, which includes being able to moderate really wonderful panels like today with my colleagues, Laura and Andrew. So I'm going to jump in because I want to make the most use of the time that we have. And I'm going to kick us off by asking Laura and Andrew to introduce themselves and their work in the housing first and harm reduction approaches. And could you, as part of that introduction, highlight an example of how you've seen harm reduction programs and housing providers partner together successfully in the work that you've accomplished? And I'll start with Laura.
Good morning or afternoon, Massachusetts. I'm Laura Guzman. I'm Senior Director of Capacity Building and Community Mobilization for the National Harm Reduction Coalition. Like Emma, I oversee the California work and have been doing this work since the 90s, and also have the blessing to have started doing harm reduction in housing, which is actually pretty unique. A lot of the work in harm reduction started doing syringe service programs, but I had the blessing to land in 1995 in San Francisco at the Ambassador Hotel, a place that was the only refuge for people who were dying of AIDS, who used drugs. And that was where my harm reduction journey began. And since then, I worked in the field of housing and homeless for almost 25 years in San Francisco. I also was the Continuum of Care Director in Alameda County, so very familiar with sort of the HUD housing first models. And in the last two, I've been working with the Harm Reduction Coalition. And most recently, I'm just going to share the most recent example. We started a pilot of overdose prevention in housing. Since in San Francisco, we see the impact of overdose death, particularly in people living in single residential hotels. And we started a pilot with state funds via federal funds. And we got an expansion to provide training to staff in supportive housing, but also, most importantly, to actually train and support peer specialists, the very tenants who are actually catalysts to be able to pass Narcan and to intervene in overdoses in housing situations. So I'm very, very blessed to be here with all of you. And Andrew, I'll pass it to Andrew.
Hi, everybody. Good afternoon. I'm so honored to be here among colleagues and friends, Emma and Laura, and everyone from RIZE. So thanks for having me. My name is Andrew Spiers. My pronouns are he, him, and his. I'm the Director of Training and Technical Assistance at Pathways to Housing, PA. Pathways is a homeless services organization that's been using the Housing First model to help end chronic homelessness for single adults who are living with serious mental illness and or substance use disorders. We've been doing that since 2008, and we're currently housing over 550 participants in a scattered site model all over the city. We're pretty good at what we do. We have an 85% housing retention rate after a 5-year period with the very folks that were considered, not ready for housing by similar programs. So I've been with Pathways since early 2018. I started out in a clinical leadership role, working directly with our participants and supervising members of our Non-Fidelity Act teams. And for the last 2.5 years, I've been director of training. So managing Housing First University, which is our outward facing training and education initiative, where we work with folks all over the country and really all over the world now in, helping folks learn more about the Housing First model, harm reduction, integrated care, service delivery best practices. Prior to coming to Pathways, I worked specifically with transgender folks in an inpatient residential drug and alcohol setting. I've worked with returning citizens. I've worked with Prevention Point Philadelphia and harm reduction. So a lot of my previous experience like lended itself really well to what I'm doing now. And I'll say some of our successes, housing itself is a form of harm reduction. We know that once someone is in a home, we're keeping them safer and healthier than they would be living outside on the street. Our most recent clinical team that we launched, Team 9, we just named them in order of appearance. Team 9, we housed 75 individuals with polysubstance use disorder who were experiencing chronic homelessness between March and September of 2020. So really during the height of the pandemic, recognizing folks who were super vulnerable, our amazing direct service staff really rallied, worked all throughout the pandemic and helped bring more folks inside to kind of protect their health and safety. So we're partnering with Prevention Point Philadelphia and Project Home. We operate a satellite site of the Stephen Klein Wellness Center, which is a federally qualified health center on site. We're providing low barrier MOUD. We have MAT case managers, nurse practitioners, a physician, and everyone, working both in the offices, but we're community and mobile based as well. So that's a little bit about what we do.
Thanks, Laura. Thanks, Andrew. And I'd certainly recommend for folks that want follow-up training to really look at the university and trainings that Andrew's team and Pathways to Housing provide to complement the information that we're providing today. So I'm going to move to a really common question that I've had come up as well for me when I've been working with housing providers in the past is this concept about the balance between empowering people who we're housing, who are actively using substances, and maintaining the safety of everybody involved in, in the programs or in the housing provision. And, and we know that a key principle of harm reduction is like empowering people who use drugs to have autonomy over their choices and their priorities. How would you say you and your teams have been able to kind of strike that balance, right, between maintaining the safety of all staff and residents whilst honouring the principle of autonomy in harm reduction? Andrew, do you want to kick us off with that from your experiences?
Yeah, sure. These are conversations that I'm used to having all the time with other folks as well. More traditional kind of recovery first or services first before housing stability, linear residential treatment models, all of that is kind of based on this like provider knows best attitude or these clinical assumptions about what our program participants are and are not capable of. And what's important to note about those approaches is that they're not evidence-based, right? They're kind of the way we've always done things, but we have kind of the data that shows that they're actually not very effective. So when folks talk about, we're worried about, using harm reduction or incorporating harm reduction into our work, one of the things I remind folks is like, we're already doing harm reduction with people all the time, whether or not we realize it, right? So having conversations with individuals about their substance use, is part of harm reduction, right? We keep folks safe by having open, honest, direct conversations that are practical and realistic, right? So, some of the simpler tools to keep people safe, obviously, unlimited supplies of naloxone for our participants, for our staff, for our community partners, even all of the landlords that we're working with are trained in how to recognize and respond to an overdose. We're providing fentanyl testing strips. We're talking to our participants about not using alone. We're connecting folks to Prevention Point Philadelphia for safer injection supplies and smoking kits. Sometimes our participants will just call us on the phone if they don't have anybody around and they need to do what they need to do, but they're at risk of an overdose. And we'll either stay on the phone with somebody or call them back within a set amount of time, or know if we don't hear from them that we should contact emergency services and alert them to that location. So, we work with folks kind of where they are, right? We offer that low barrier MOUD program on site. We're not kicking folks out of that program for losing their subs or asking for them early, right? And what we find is when we really kind of meet people where they're at on their substance use journey, 63% of Pathways participants are getting connected to some form of treatment within 6 months of getting housed with us. That's more than triple the national average. So if you look at the number of folks diagnosed with opioid use disorder in the United States, about 20% of people ever access any kind of treatment, right? And those are folks that have maybe never even experienced homelessness. So our folks who have maybe a lot greater barriers kind of in the way are seeking treatment at higher rates, because we're centering that participant self-determination and autonomy and really helping our participants pursue their goals as they've identified for themselves in the order that they want to pursue them.
Thanks, Andrew. Laura, do you want to share any responses to what Andrew said?
Well, I'm just going to say everything that Andrew said. And I wanted to focus a little bit, since I managed a homeless drop-in center for 16 years, a navigation center, one of the first in the country in San Francisco. And then we also manage and did support services in housing. I want to say to Andrew's critical focus on how do we honor that autonomy. I also want to say the flip side is the way in which stigma actually prevents our participants to really do well in any setting, whether it's a street setting, whether it's interim housing setting, or in actual housing. And I also want to say that in San Francisco, we did a 6-month project, focus groups, interviews with participants of homeless and housing programs, where the participants themselves kept saying the way in which I'm treated makes me feel really not only uncomfortable, mad, no wanted to stay, no wanted to really engage. And so one of the things that are very key from a harm reduction perspective, which is do no harm, and most importantly, really work on the stigma issue, because part of the behaviors that sometimes we see in our community are directly related with the shame that they feel as a result of the stigma. So just to give some examples, during the when there was the peak of crack cocaine smoking, we had a drop-in center, we had a patio where people could smoke, thank God, so they didn't have to bother neighbors. And if people were smoking crack and were caught, we would not just say, you're gone. We actually had a conversation. Our rules make sure that people had a warning, and that we talked about what would be safe spaces, which of course there weren't that many safe spaces for people to smoke crack, because if they did it on the street, they will be also probably targeted by police. But to have those conversations and never shame anybody, for example, for using drugs in the premise. In the context of housing, same concept. We managed one of the few housing projects for Latino immigrants, mostly males, many who came from histories of trauma in Central America, others who've been homeless for decades, because there was no help for, in particular for immigrants. And so there was a big degree of drinking in the common areas. And we worked with people for years, and people were retained by actually not only having conversations, but all the time really talking about the individual versus the community impact. And so in harm reduction, we also are not shy to differentiate what's the impact to the individual versus what's the impact to the community. So I think it's very important to be mindful that how we talk with our community actually has a great degree of impact in the way that people actually not only do buy in, but also abide by community rules. And talking about community rules, I got to read, as a continuum of care director, the rules of a lot of programs, in particular in the Alameda County where I was working. And I was dismayed by the things that were in community rules in many projects, which will be an automatic dismissal from a program for young adults for perhaps having just smoked a joint. And so they would end up on the streets, versus that program actually working with someone who may have just had a touch of weed to make sure that we do not, and this is a big principle of Housing First, we don't evict, we don't terminate immediately because someone is using drugs. So that is what I wanna say. And we hold the community accountable if the impact is about safety, if the impact is about harming other people, not necessarily the drug use per se. And that is the shift of the harm reduction glasses and lenses that Andrew and I are trying to share with you. The bottom line is impacts that are harmful, not the drug use per se.
Yeah, and I think a lot of the folks that we work with think about the behaviors that are maybe kind of associated with the drug use as separate from the drug use itself. The problem, folks identify the problem as the substance use, and it's like, no, the problem is actually some of these other behaviors that can come with the drug use, right? So it's not that somebody is using opioids. It's that there's a lot of people in and out of the apartment, and it's disturbing neighbors at 3 o'clock in the morning, right? So it's like that behavior that we're focusing on, not necessarily whether or not somebody is using substances. And I also think, because of the stigma that Laura was talking about, right, a lot of our service providers have this kind of fear of working with some of our participants who use drugs, right? And how are you going to help somebody if you're afraid of someone, right? And recognizing the way that kind of that stigma and implicit bias kind of rears up in us all of the time, but also recognizing there are some real challenges. In Philadelphia, a lot of the neighborhoods where we can afford to rent apartments for our participants are neighborhoods that have been greatly impacted by the opioid epidemic and are disproportionately impacted by poverty and neglect, right? So they're not always the safest places to navigate, right? That's why it's important that we're hiring folks with lived experience and folks who are community, like on the ground workers, know how to navigate these types of neighborhoods, have existing relationships with folks in these neighborhoods, right? We're also not, we're sending people on 2-person home visits when necessary. Implementing an emergency phone notification system is something that's newer to us because we do want our staff who are out in the field doing this work to feel as safe as possible. So, ongoing trainings for personal safety, crisis intervention, de-escalation, all of that is an important part of the work too.
I may just want to add, thank you, Andrew, to this discussion, the component of the impact of racial inequity, in the fact that when we're working with folks who are unhoused, in my experience, primarily Black and Brown and Indigenous people, definitely some white folks, poor white folks that have ended up on the streets. But I want to also emphasize that in addition to all of the impacts of, a very violent system, a very racist system across the board, not just in housing, in public health, in our, the way that we criminalize our folks are already impacted by histories of trauma and oppression. And therefore, the way that we go about actually making them feel whole, that's what we talk about people who use drugs, not drug users, not drug addicts. These are humans that have accumulation of impacts, and therefore how we intervene in a drug use, quote unquote, drug related situation will make a difference about how are we honoring those folks to feel human, real, listened to, and deserving of help.
Mm-hmm. And I think the next question I have is piggybacks on to that, Laura, in terms of how, many of our folks, they are disproportionately come into contact with the criminal justice system. And you gave an example just before about how, you were holding conversations with people about, where are you going to smoke your crack, right? How are we going to minimize you getting into trouble, or getting stopped by the police if you're doing it on the street? Are there any other examples that you can share? Because I know people were interested in this from the pre-survey about how to reduce harm for folks that may come into contact with the criminal justice system that are kind of involved in housing first programming.
I can go quickly with a couple of examples. I also want to say what needs to be reformed is the system, of course, not the people. But having said that, one of the examples we had was in navigation centers. I know that Andrew's program also have some similar models. The navigation centers, we opened the first one in San Francisco, and the idea was these are projects to provide interim housing with the quick exit, as long as we were building housing and securing funds to be able to house people. But in the navigation center, we had people on track for housing that had warrants in other states and or warrants across the Bay, right? They might have warrants in Oakland, they might have warrants in Oregon. One thing we did is we actually helped our folks to go to be able to quash those warrants. Many of those warrants were old. There were warrants that were there were a real barrier for them to get housed. And actually we flew people to Oregon. We drove people to Oakland to, and talk to, the law enforcement jurisdictions to quash this warrant. So that's an example where doing that active work is critical work to break the barriers. I also want to say I found in Alameda County doing my first technical assistance year, I was looking at leases. I told you house rules. Leases, some leases in housing settings are very old. I found leases from 1975. I found leases that said that people will be kicked out if they smoke pot in their unit, even though pot is legal in California. And so one other area where there is an incredible need for us to really look is to see if the actual rental, and Andrew may have a lot to say because works with landlords, is the the leases themselves are actually legal and whether they are compliant with Housing First. So we did in Alameda County make sure that every housing provider receiving had funding was going to make exceptions in their leases that will actually be in line with Housing First. So for example, people will not be evicted just because they were caught smoking a joint in the room.
In Philadelphia, a large number of our participants have some involvement with the criminal justice system, prior to coming to us or ongoing while they're with Pathways. But we find that often just housing someone significantly impacts their continued involvement, right, with the criminal justice system. Our participants are often incarcerated because they're engaging in survival crimes, and their need to engage in those behaviors is significantly lessened once someone has a stable place to live and a refrigerator full of food and all of the other resources that we provide that can help someone kind of attend to their basic needs. So, for folks who have maybe been incarcerated because substance use issues or kind of mental health challenges, simply moving those symptoms or behaviors inside and off of the street, right? Less police surveillance, less encounters with the police that could lead to an arrest or incarceration. And we're also getting folks connected, to substance use services if they'd like that, to psychiatric treatment if they'd like that, right? And it makes a huge difference. One program study we did found that participants in our program, their episodes with the Philadelphia prison system decreased by 50% after being, with our program for a while. Number of days in the Philadelphia prison system also decreased by about 45%. And even when folks do experience incarceration while in the Pathways program, we don't just discharge them. It's not someone's incarcerated, oh, we can't work with them anymore. Right. We just go to visit them wherever they are until they get out, right? We have forensic liaisons on each of our teams who are going to the jails and prisons and meeting with folks, talking with them about what's going on, showing up to advocate at their court dates. And we actually have a number of folks now with us under a specific program called the High Five program that works with individuals who have high rates of recidivism. So this lets us kind of circumvent that HUD rule that once somebody's out of the unit for 90 days, we have to give up that subsidy to somebody else. The High Five lets us keep that person's apartment for as long as is needed. And it also provides folks with a little bit of a financial stipend, right? And so what does it mean for somebody to just have a little extra money in their pocket? And how can that prevent engagement and behaviors that could lead to incarceration again?
We did the same thing at Casa Quesada. We make sure that our folks who may have ended up for very small cases or any cases, to make sure that we were preserving their lease, that we stayed in contact. Our support service team make sure to be in contact, continue in contact with jail services if there was medical services needed. And so that continuity also brings trust and brings the fact that, again, the goal of success in supportive housing is to retain people in housing. So we do whatever it takes is the approach that we call it. I just saw something in the Q&A. I feel really compelled to respond because I started doing trainings on harm reduction housing in the 90s when housing programs were transitioning to a harm reduction model. And I cannot tell you how many housing providers I've seen where staff was actually taking the role of police to basically go into a room, search for paraphernalia, assist to an overdoses, see the paraphernalia, and actually feel that they have some responsibility to be police and policing people's drug use. And I want to say that is the most dangerous premise, number one, because property management staff should actually be managing. They should be observing and reporting, but there is nothing in their job descriptions to police the drug use of people. So I just want to say this is one of the dangerous paths that sometimes sometimes staff does it because they really want people to be well. They have good intentions, they have their own recovery in the midst of these discussions, but it's very important to understand that the role of property management or support services is not to police drug use. It's to document or report if that's the case. It's for support services to follow through with that person that may have gotten, a note because they were, smoking pot or drinking in the common area, but it's very important. And also to honor people's decisions to do what they want to do in the room, unless smoking is not allowed in the building. So that's just my addition to that question. I don't know, Andrew, this is a question about when staff polices drug use.
Yeah, I think it's always important to remember, like, behavior serves a function, right? And people are using for all kinds of reasons, and it's not our job as service providers to assign like morality to those decisions or say whether or not those decisions are good or bad. It's not if it's not yourself and your body and your home, right? Allowing our participants to make the decisions based on the options available to them and what feels best and what feels right for them. And the most important thing is supporting folks and not kind of abandoning folks just because we don't agree with the decisions that someone is making. And what we do find though, right, is once we get somebody into housing, once folks have more options for engaging in the types of support services they want, when they want to, folks might prioritize like other goals before they get around to like starting to explore their relationship to substances. But we find that the longer folks are housed, they start to trend in the direction of maybe the goals that we would have wanted as the providers, right? Like I said, 63% of participants are involved in some kind of treatment within 6 months of getting housed. And we do have participants that might eventually make their way all the way towards, abstinence-based recovery, but it's just not our goal to kind of prioritize that or push that on folks if it's not something that they've expressed interest or desire in. And we have individuals who have been in our programs for as long as we've been around for 13 years. We have participants who have been with us since the very beginning, whose relationships to substances has changed over time. And so I do think it is quite sustainable to really allow participants to make their own decisions about how they're managing their own substance use, as long as we're continuing to show up with all of those other supports.
Thanks, Andrew. Thanks, Laura. So I want to kind of shift a little bit to talk about working with communities, neighbours and landlords. And if you can share kind of any of the ways that you've been able to successfully work with those folks and other community stakeholders in applying, a housing first approach to really kind of build that kind of support around, the folks that you're trying to house and the provision that you're trying to provide. What are some examples that you'd want to kind of let people know about that have been successful for you? We want to start recording. There we go.
Andrew, do you want to go first and talk a little bit about your landlord? Because I think it's a very important.
So for starters, we work with a scattered site model in Philadelphia. That means we're renting vacant market rate apartments all over the city. We don't have a big congregate building. And one of the reasons for that is that prevents the not in my backyard kind of attitudes, right? We don't have to haggle or argue with community members or folks who are not interested in having, those people living in their neighborhoods because our participants are scattered throughout the city and integrated into the community fully, just like everybody else. We believe that that's also really helpful and healing for our participants. They get to learn what it means to be an involved, integrated member of the community by being in the community, right? We also practice master leasing. So this makes it a lot easier for us to house folks who maybe have bad credit or evictions on their records, or a criminal history, right? So Pathways is actually the leaseholder with our landlords, and then we're essentially subleasing to our participants. That being said, we still have to get landlords to agree to work with us, right? And when we started in 2008, we probably had a handful of, somewhere between like 5 and 10 landlords to house the 70 participants that were on our very first clinical team. And today we're working with probably somewhere between 65 and 75 landlords to house 550 folks all over the city. So that really requires us to help folks understand, landlords, community members, et cetera, understand what it is we really do and our mission, and get folks to invest in that, right? And want to partner with us in that. It's in 2022, all of us know someone who has struggled with mental illness or has struggled with substance use, right? And so helping our community partners and our landlords see that our participants are somebody's family member. That's somebody's sister or brother or daughter, right? They're not just like those scary people disconnected from the rest of society, recognizing that this can happen to anybody. Homelessness can impact anybody. And so, helping landlords understand that they get to be a valuable part of the mission of ending homelessness in the very communities where they're living and working. And then for the landlords that don't buy that, and that's not enough, we figure out ways to incentivize partnering with us. So maybe we'll say, hey, just give us a 6-month lease instead of a year lease. If you just want to try it out, give us a couple of months and see how it goes. Maybe we offer to pay, they're asking for $800 a month in rent for their 1 bedroom. And we say, how about we give you $850, right? And then see if that doesn't tug on their heartstrings a little bit and get them to work with us. We're also always providing professional development opportunities for our landlords. We're training them in mental health first aid, and like I said, recognizing and reversing an overdose. These skills help landlords with all of their tenants, not just tenants who are members of a program like the Pathways program. Landlords are working with folks all the time who are struggling with mental illness and substance use issues. They have family members and other community members who are struggling with these issues. So the skills that we're imparting to our landlords are transferable and helpful to all areas of their lives, not just their work with our program participants.
Mm-hmm. And there's a question in the chat, Andrew, and I don't know if you would add anything about how do you approach having those kind of conversations with landlords? Is there anything else you'd add to what you'd said around that?
Well, when we first started our housing program in 2008, it was our director of housing, John Lambert, who's been with us since the very beginning, is still our director of housing, who built everything from the ground up, right? And he'll say, even he himself, when he was first approached by our CEO, Chris Cimariglia, about helping to start this Housing First program, he was like, I don't know about all this. Is this really going to work? And so he was very transparent with our landlords in the beginning about I understand your skepticism, right? And I'm not here to change your mind necessarily. I just want you to give us a chance. And then citing some of the research. I mean, Housing First has now been around for 30 years. It's been an evidence-based practice, registered with SAMHSA since 2007. So we do have the data to show that Housing First programs are very effective. So that can help. But it's always just like listening to our landlords' concerns sincerely and then responding with kind of the education and facts. But how we've identified those folks has been everything from cold calling people off Craigslist to knocking on doors, calling ads that we've seen in the newspaper. And it takes a lot of footwork in the beginning, but it pays off in the long run. Because once you get a couple of landlords who are very happy with your program, they're going to tell all their landlord friends. And we're at a point now where sometimes we have more landlords knocking on our doors than we actually need. So it's a lot of heavy lifting up front, but it'll pay off.
Mm-hmm. Thanks, Andrew. Laura, what would you add kind of to working with community stakeholders and
I think that I'm not sure how it works in Massachusetts, but every time we opened a navigation center, every time we opened housing for our communities, we had to do a lot of community, what we call community outreach and networking, and also come with what we call good neighbor policies. So whether it was our opening of our first navigation center in the heart of the Mission District, I work in the Latino district of San Francisco, or when we opened Casa Quesada, we had to basically build relationships for a year prior to opening the program with the neighbors to one, have a clear understanding of what our model was. As Andrew was saying, make sure that the neighbors understand the types of supports that a particular housing project brings, because I think that reduces anxiety. And after opening, really maintain very close relationships. We did it for our drop-in center. I mean, we actually took care of the entire block. We even cleaned up that entire block more than the city did. And so this idea of taking care of neighbors and community as we are opening programs, because there is a lot of misconceptions about what a housing project is. Once you bring the idea that this is bringing folks that might have, whether it's dual diagnosis, histories of mental illness, or people who use substances, which was our model in San Francisco, brought a lot of questions and challenges from neighbors. So in addition to landlords and our community partners, it's very important to really start that work early on and to really work closely after opening a program to make sure that we align. We've done visioning work with neighbors where we decided this is what we're going to do in the next 6 months, and we actually gave awards to our neighbors for working closely with us. We had a motorcycle shop that sponsored all of our community programs, and so we will wear actually the mechanic shop apron when we were doing picking needles on the street. So that building of relationships with the folks around us is really important because of, again, stigma, misconceptions, and also neighbors want to know that we're going to be also good neighbors as we move into particular facilities. So that will be my addition to that question.
Thank you. The next question, the next thing we wanted to talk about was how we kind of are defining success for folks and exploring how to support residents who may be struggling. In adopting harm reduction housing first and harm reduction approaches, what has been your approach to defining success for residents, and how is this connected to supporting residents who may be successful? And from my own, I'll kind of share an experience from my own kind of capacity building work. We're working with a housing provider in New York where they wanted to really kind of focus on genuinely integrating housing first, and we took a look at their their evaluation and their policies and practices, and we had to really help them think about redefining what success meant for them with their folks, because previously their success was connected to people not using drugs, and people, so like really rethinking like how are you going to measure your success, and I wonder if you could speak to that from your experiences.
Well, I can just talk about our SRO program, and I want to also say Sarah Porter let me know that how I answered her question was not exactly how she was expecting. So I'm going to use the SRO project as an example of success, not just for the residents, but also for the teams that we're working with. And that includes, amplifying the way that we do overdose prevention in housing. So the SRO project was conceived model after a project in Vancouver that was called the Toro Project, which was doing overdose prevention by training the tenants in private single residency hotels. So these were not supportive housing, and actually supported them because the majority were First Nation people, to have a cultural model of overdose intervention that meant passing Narcan, saturating naloxone, training the staff in housing, and training in particular other residents. And so we adopted the model and did 2 site pilots. One was with our partners from DISH. DISH is a fabulous and actually a harm reduction based property management company in San Francisco, which we have partnered for decades. And we had the Department of Public Health as our partner, and our team which started to do inside training. So basically looking at the policies of the housing projects to look at whether or not passing Narcan by staff would be appropriate, training the staff to actually administer Narcan, and in addition, recruiting, doing all resident training and recruiting up to 6 resident specialists that we train more specifically to have Narcan available, to pass Narcan and train other residents and to intervene in an overdoses. So this was our pilot, which is now we're going to be expanding to 10 sites, including new housing that is going to be opening very soon. And what we learned in particular in our partnership with Dish, they added Brave buttons, which some of you may be familiar or not, but Brave buttons are those devices. Now they're used with elders as well, where you can push a button to alert. It could be 911, it could be the front desk. In this case, we adopted the Canadian Brave buttons, where folks were able to, from their room, activate and connect with the front desk, to connect with the peer specialist. So in the case of an overdoses, they could actually respond. We were working this collaboration again with a housing program that had that commitment. But what we have been able to do through the program is look at the resident feeling of success, the residents feeling seen, feeling that they have the expertise not only of drug use, but also of using Narcan in the past. Having the resources available, we mounted wall mounts throughout the building. So we have wall mounts in every floor, so they have access to those wall mounts. And then we're checking with them. So we do a period of time of 3 months where we're doing training technical assistance, paying them for their contribution. And I think the success is that now the building where we have been implementing this has really overdose as part of their safety response. And this is kind of one of the, if you wish, to me, in this really dangerous moment of overdose death in the country with a very chaotic illegal drug supply, if we can have that as a measure of success, that we are really saturating naloxone in all housing and that we're training staff and activating the residents to be that mutual aid and actually the best responders, to me, that is incredible success that can really trickle other harm reduction interventions in housing. So that would be sort of like my example to share. And Andrew, what is yours?
I got a lot. I think defining participant success is going to be different for each participant, right? If we're really centering participant goals, then the success is, are they achieving the goals that they have set for themselves? The answer that you want to hear and looking at like a more kind of like programmatic and operational kind of level, obviously, as we've already mentioned, our #1 goal is to keep people housed. And so if we're keeping 85% of our participants housed after 5 years, when they're the folks that no other program would even touch or consider housing, I would say that's a success. Mm-hmm. Other successes we'll look at less frequent visits to the emergency room, less frequent, fewer psych hospitalizations, fewer medical hospitalizations, increased participant satisfaction rates, increased medication adherence, more kind of robust involvement in the community. So with volunteer work or employment or engagement with faith-based communities, folks getting connected to primary care, either on site in our office or in the community, folks who are receiving all of the benefits that they're entitled to, folks who cure their hepatitis C, all of these things are ways that we're measuring success, right? Mm-hmm. Our program studies that we've done have shown that, once connected to our program, shelter episodes or like, recurrence of returning to a shelter decreases by 88% for our folks. Number of nights in the shelter decreases by 87%. Crisis response center episodes decreased by 71%. Mental health court episodes decreased by 11%. CBH hospitalizations, community behavioral health, that's our, managed care behavioral health in Philadelphia. Those episodes decreased by 70%, right? All of those things are measures of success for our program. Things that at the onset, when we started, that folks never thought possible are happening all of the time now. We have a Work First program. So Pathways to Housing PA also operates the Philadelphia Furniture Bank. So early on, we realized we were spending way too much money on couches and futons and beds for folks. Meanwhile, hotels, universities, estates are throwing perfectly good furniture in landfills all the time, right? So we opened a warehouse where we collect furniture donations of gently used furniture, or even if it's a little broken, we got a little repair shop on site. And we have this whole warehouse where when somebody gets connected to permanent supportive housing, they can come to our, or rapid rehousing, whatever. They're exiting homelessness, they need furniture. They can come to our warehouse with their case manager and go shopping, right? They say, I want that bed, I want that lamp, I want that piece of art for the wall, I want that chair, that dining room set, right? Talk about like enabling like choice and participant self-determination at every stage is like helping folks really feel like they're creating their home how they want it, right? So we have this furniture bank and our participants can work there, right? Maybe they have a big gap on their resume and they just need to build up some soft skills. They can go work at the furniture bank for a year, and it's just, you don't have to show up clean and sober. As long as you can show up and put in a day's work, you're gonna get paid for that day's work. It's gonna pad your resume. We're not gonna fire you if you like miss one day, right? And so that helps folks. We're starting a junk hauling business called Good Haul. So we're actually gonna be able to go pick up more furniture, and they'll work in tandem with the Philadelphia Furniture Bank. Participants will be able to work in that program as well. And now we're seeing folks who are really, we've had a step down team for a number of years, folks who came in at this very high level of care and then made a lot of progress, right? And they're able to step down to a lower level of care in-house, where their team, the only difference in their team is that they don't have a registered nurse on that team, and there's no psychiatrist associated with that team. So at that point, we're encouraging folks to really be connected with community supports for their mental health and for their physical health needs, but they're still maintaining case management services with us. Mm-hmm. Now we've seen folks do so well in our step down team that back in September, we graduated our first ever class of participants from Pathways, right? Folks who we thought would always need to be connected to services have just kind of blown us away with what folks are actually capable of. So we've been able to transfer those folks to Philadelphia Housing Authority vouchers. They stay in their apartment. We don't want to disrupt that. If they're safe and stable there, we're not saying you got to move out and go somewhere else. We just turn over that apartment to them. They stay connected to us through our alumni association, but they don't need us anymore. And a lot of those folks are involved with us in our advocacy efforts now. Will come, testify before Congress with us, or go to conferences with us and talk about all the success that they've been able to see. So it looks different for everyone, but a lot of the success that we've achieved is really beyond anybody's kind of hopes of what was possible when we first started.
Mm-hmm. Mm-hmm.
Andrew, there is someone want to get your data, and I just want to say for the audience, there have been so many studies in the last 30 years of the efficacy and success of permanent supportive housing for people who are, what we call quote unquote chronically homeless, which means people who have both histories of, trauma, mental illness, substance use, and other health impacts. I just share one from UCSF, very recent. There are studies done in Los Angeles. There were studies done in New York. So if it is to look, and I'm sure Andrew can share their own data, lots of studies have shown that permanent supportive housing is actually the cheapest option. We choose not to build housing, not to subsidize housing. I know there's a lot of questions around resources in the chat. People having to have income to pay for housing in a country that has done very little to actually, since the 80s, has not really amplified housing, the levels of housing funding that we had in this country, right? Whether it's Section 8, whether it's even our, had funding for housing and homeless programs. So I just want to say lots of studies. We're going to give you some at the end, some other resources, but there's a lot of studies that have been done that show the proven effectiveness, as well as a good fiscal practice, rather than spending tons of money on criminalization, tons of money on temporary housing. So,
oh my gosh, yeah. If you compare how much it's cheaper to put somebody in a housing first program than it is to allow them to continue to be homeless, right? If you add up all the costs associated with nights in the shelter, psychiatric, involuntary hospitalizations, police interventions, soup kitchens, all of that, right? Emergency room visits, that's so much more expensive than subsidizing some housing and providing the appropriate wraparound support services. Inpatient rehab programs cost about $155 per night. Congregate housing costs about $113 per night. Housing First costs about $80 a night. Right? It's cheaper, it's more effective, it's good for the individual, it's good for the community at large. And especially when you're doing like a scattered site, right? We're renting from local landlords, we're retaining the local tax base. I mean, it's like really a win-win-win across the board. So.
Thank you. I have one last question to share that came in from the pre-survey. People were really interested in exploring how to build sustainable collaborations, and this includes collaborations in relation to funding sources and kind of sustaining your programs that way. So can you share examples of your experiences of building sustainable collaborations, including anything around funding opportunities? And then as part of that, if there were any particular challenges that you had to overcome in terms of building those collaborations to support your programming and organization?
So I think when it comes to this Obrama, I think I started by saying initially we went for the very time, I think it was a year grant through the state of California, as we saw the incredible rise of overdoses. And just for context, versus Massachusetts, in San Francisco, our numbers of overdose death were very low because we've been doing through our DOPE project since 2001, deep, broad, community-led naloxone saturation in the hands of people who use drugs and the people that serve them. So we saw from 200 deaths flat until 2018, a sudden double in 2019 to 400 and some, and in 2020 during the epidemic, it jumped to almost 800 deaths. So what we did was a couple of things, talking about sort of like how do we augment resources, how do we collaborate, have the conversation with the Department of Public Health that we were really interested, and they were very interested to really scale up this pilot. We also work collaboratively with our board of supervisors to actually pass an overdose prevention and response policy, because the Department of Public Health had harm reduction in their sort of like policies and practices since 2000, where every other department in the city haven't. So housing, as an example, the Department of Housing and Homelessness to this day has not yet resourced in scale what we're trying to really push for. And so the augmentation of $1 million in the last, so we got in July through the Board of Supervisors and the mayors, is this intent to push new overdose policies throughout the systems of care, including the Project Room Keys, the SIP hotels that were, born out of COVID, all of our supportive housing stock, including scattered housing. So we're really pushing really hard right now. We got $1 million to do this particular model in 10 sites, but our goal, and we're partnering with supportive housing providers and the Department of Public Health, is to really push the envelope for Narcan saturation, training for staff, frontline staff in housing around overdose prevention and response, and also elevating peer specialists as the key people that can really sustain these interventions in housing. So as an example, where we started with a little pile, then the city was gracious to really give us this opportunity to amplify our project. And we're not gonna end until we really are able to have overdose prevention, what we call everywhere in San Francisco. So that's sort of like my current example. Andrew?
Yeah, this is like the number one question everybody asks is like, how do you pay for all of this and how does this work? So, the easy, broadest overview is we've got two major pots of money. We have the HUD subsidies that pay for our housing, and then we bill Medicaid for our supportive services. So those wraparound supportive services, case management, all of that kind of comes from billing Medicaid directly. I know that's more challenging in states that don't have Medicaid expansion, but certainly we have a bunch of smaller contracts that kind of help pay some of those other bills that are not covered by those two pots. So contracts with the Office of Homeless Services in Philadelphia, by the Department of Behavioral Health in Philadelphia, fill some of those gaps. We have a very robust fundraising program. We apply for a lot of grants, and the idea behind Housing First University is we're going to share some of our expertise with folks all over the country, all over the world. And once we break even, any profit we turn goes right back into serving our participants and meeting their needs. So I saw some questions in the chat around, do participants pay for the housing at any point? So we're permanent supportive housing. We're never going to ask folks to kind of foot the bill for services at any point in time or for their apartment. But we do ask that participants contribute 30% of their income as part of their program contribution. That's if they have income. If they don't have income, they don't pay anything, right? If they're entitled to income and they're not getting it, we're going to help them get that income. But yeah, we're not charging folks rent unless they have some kind of income to offer. So obviously we're partnering with Project Home, as I mentioned, Stephen Klein Wellness Center, Prevention Point Philadelphia, Jefferson University Hospital, kind of help collaborate on our work and sustain us. And another thing that we've recently noticed is, well, not that we've recently noticed it, but there's a dearth of affordable housing in Philadelphia, just like there is everywhere else in the United States. There's not enough of it to go around. So we've recently started Pathways Wellness Corporation, where we're going to be developing some affordable housing in the city. And some of it might be used for our participants, but it's just generally affordable housing that's going to be there for folks who need it in Philadelphia, because yeah, it's getting harder and harder. So working together, finding these opportunities, Philadelphia Furniture Bank, Good Hall, all of these kind of endeavors help support the services that we're doing with our participants directly.
I want to add to this Andrew's contribution and the question about resourcing. For example, when we did Casa Quesada in San Francisco, we committed San Francisco to do local subsidies to pay for the rents of people who are immigrants until they die in place. In fact, these folks have been housed since 2011. 89% of the people we place in housing, they're still there. I hang with them. They're now old like me. And so they're aging in place. And there were folks that otherwise would not have gotten any subsidies from the feds or anywhere else. So investing locally is very important. And that means that every jurisdiction is going to have to really step up this idea that for people who have no income, you are subsidizing their rent until they die. And this is very important from a racial equity and equity perspective. A lot of our folks who are homeless as a result of policies and practices. The fact that we have not built affordable housing for people who are extremely low income or haven't put any funding. And so I want to say this is also an appeal to the state of Massachusetts, to the jurisdictions, to be creative. Do we spend all this money, as Andrew was saying, in opening a shelter that is only going to serve the people's needs for this amount of time? Or do we put that money to subsidize long-term housing? And this is the key issue in this country. It's not Massachusetts, it's true in California, is our commitment actually in trying to talk about housing and harm reduction we should all be fighting much harder to make sure that housing for people who are extremely low income and low income happens. So I just want to say that's why requiring income is an issue. I know there were a lot of questions, but it's because we don't have the ability to subsidize if we're not budgeting enough money so people stay housed. And so we have this dichotomy. We feel so strongly when we see people using on the streets, but we also not working hard enough to really assure that we are building, not only building the housing, but like Andrew says, that we're subsidizing the housing. So I just want to say something, out of 35 years of this work, this is what still breaks my heart. And also I think that's where we should put a lot of our efforts. We recently polled, so we have a California initiative. We are polling our participants of syringe service programs every 6 months. And we have learned that in California, 75% of all the syringe service program participants are unhoused. We also polled those that are using, in particular, methamphetamine, because we know it's a drug that really has high stigma and a great barrier to housing. And when we ask them, what do you need for treatment? They say, 1, spaces where we can hang and feel human. 2, housing access, right? And that meant included, subsidizing and support. And then treatments that will really benefit people who use meth, because we have a lot of emphasis on opiates and not on meth. So just to add to the fact that when we see that 75% of participants in California are houseless, tells us something about the barriers of housing for people who use drugs. And I'm sure that it replicates in Massachusetts and in other jurisdictions. So I just want to give also I know there's policymakers in this room. I know there are folks in the treatment world. We need to get our heads together to say, what is the bang for our money, and that will honor the dignity and respect of our communities.
Thank you, Laura. Well, that's kind of the main kind of section of questions that we had that came from the survey. And I'm going to invite my colleague, Sarah Gorey, who presented with me in the last session, who kindly joined us again to help us with the Q&A section. And I want to say hi to Izzy, who's on the call from JRI, who put in a question. Ishmael, it's really good to see you on the call. Thank you for joining us.
Hello, everyone. Wow, thank you, Laura, Emma, and Andrew. This has been an incredible discussion. Thanks for sharing your insights, perspectives, collaborations, funding tips. You have really captured the keys to what it means to provide low threshold housing. Hi, folks. My name is Sarah Gorey. I am a consultant with the National Harm Reduction Coalition, an addiction policy grad student, and I worked in the Housing First field for about 7 years. And I'll be moderating the Q&A for the next 30 minutes or so. I've seen that we have had some great discussions that came in during our panelist discussion, and so I have those logged, but please feel free to continue using the chat or the Q&A function to ask a question to our panelists, Laura Guzman, Andrew Spiers, and our moderator, Emma. I hope you answer some questions as well, Emma. And so, yeah, I'll kick it off and highlight, I think we've gotten a few questions, and you all did a great job tailoring your feedback throughout to participant questions. But really, we've been getting some questions on the operations and logistics of Housing First programs. And so I wondered if we could start just kind of briefly talking a little bit about the coordinated entry process and the continuum of care in housing coordination, and how it allows the opportunity to enroll people in housing regardless of income.
So I can do the general, and then Andrew, you can talk perhaps more East Coast. But so sometime in the mid-2000s, we started to realize that the way that people were entering housing, and this is particularly true for federally funded housing, which is still the majority of our funding, I think, in the country comes from the meager amount of funding that HUD puts for housing and homeless. Because the entry points were so many, and because participants, the very folks that were looking for housing, did not even know where to start. The coordinated entry system was actually mandated by HUD as a form of devising a way to quantify, in some ways, the needs of people who are unhoused by using different measures or different scoring measures of what makes that person to be a priority for housing. And the coordinated entry systems were supposed to be implemented by every jurisdiction that gets HUD funding. In Alameda County, we did it in 2017, actually, as soon as I entered as continuum care director. And every jurisdiction chose different measures. So for example, I'm gonna ask Andrew, is BS-PDAT the method that you use in Philadelphia? So BS-PDAT was the method that was used by a lot of continuums, and it is the method that we measure veterans, in particular, how to put veterans in housing. So BS-PDAT actually typically looks at years of homelessness and doesn't have a lot of other variables. Compare, for example, the Alameda County, we did a community process, and we decided that people with histories of incarceration, histories of drug use, mamas who were pregnant and they have 2-year-olds, all those folks, seniors, all those folks qualified to be in our priority. Once the priorities get determined, then you have the the funnel, the way in which different housing and homeless programs integrate to actually offer what's available. And this is the key. Coordinated entry systems is a great way to conceive how to get people into housing when you have the resources. So I think a lot of the challenges, and there is a great article I can share after this training that was done in San Francisco, the coordinated entry system by itself does not create housing and does not amplify the need for housing for a lot of our folks. So to make it very short, with a Via Esperad in San Francisco, we were housing people who've been homeless 20 to 13 years. That was the priority. So if you became an elder of 65-year-old, you were just put on the street, you would not qualify for housing. And that is where folks have this visceral feeling about how can that be? It's because we're not meeting the needs of the amount of housing we need. So that's my short answer to sort of like the global coordinated entry. And that should be happening in every jurisdiction in different forms. Andrew, how does it work in Philly?
You know, when folks are experiencing unsheltered homelessness, you know, we have our city's outreach kind of hotline, and you can call and say, oh, I've seen this person, they're on this corner. They look like maybe they need some help. And they'll send an outreach team to come out and engage with that person. Or they'll say, here's a list of resources. This is what shelter that person can go to based on what time of day it is and what day of the week it is. And so, typically what the trajectory of like accessing housing looks like, all right, based on your specific circumstances at this point in time, you can go to X, Y, or Z place. And so it usually starts out with like some giant congregate shelter where you're sharing space and have no privacy from like 100 other people. And then, you've got to be on time and you've got to have your medications with you, and you can't be using drugs, you can't be high. You have to have your ID, you have to jump through all these kind of hoops, right? And once you're in there, you can't be disruptive, right? And you can't be intoxicated, otherwise you can't stay there. And if you can kind of follow all of those rules for X number of months or years, then maybe you qualify to go to a slightly smaller program where you're only sharing space with 30 people, where you have no privacy instead of 100, right? And if you can do that for long enough, et cetera, right? And then maybe eventually you can get funneled towards a rapid rehousing program or permanent supportive housing program. The problem is the folks that we serve at Pathways to Housing PA cannot jump through those hoops and cannot follow those steps because of their severe persistent mental illness, because of chaotic substance use, right? So the folks that we're generally serving are folks who are on the street and have been on the street for a very long time. So usually our outreach manager will get a name and a vague description of what somebody looks like. If we're really lucky, maybe a photograph. And it's our job to just kind of go out and pound the pavement until we find that person. And then right from the get-go, we're like, the very first day we meet them, hello, would you like a house? And sometimes most of the time people are like, heck yeah, I want a house, like, let's do this. But then a good percentage of the time people tell us to bug off and leave them alone. And that just means we're gonna keep showing up. We're gonna keep engaging, building rapport, offering whatever that person wants until we've built up enough trust that they're gonna accept a home. And then we move them directly into their own 1-bedroom or efficiency apartment. And folks are able to stay there for as long as they need. We do that because we recognize that the other kind of traditional way of housing folks it's really Maslow's hierarchy if you kind of flip it on its head, right? It's not providing that basic safety and security, those physiological needs first. It's saying, sure, you can come into our program because you have to have a severe persistent mental illness or a substance use disorder to qualify for this program. But it's like magically, once you set foot through the threshold of the doors of that program, you are not to display any symptoms of either of those conditions that have qualified you for treatment, right? So it's like, well, you can have a roof over your head and a meal, but it's precarious, right? The second you do something that we don't like, you're out the door. And so to me, it's unethical. It doesn't make any sense. And really just engaging folks who are experiencing homelessness, directly funneling them into housing has been what's needed for the folks that we're serving. Because yeah, some of that linear residential treatment, the coordinated entry, it has its place, but it doesn't work for a lot of individuals.
Wow, thank you both. Laura, thank you for sharing the recent report from the San Francisco Coalition on Homelessness in the chat, and really highlighting some of the limitations of a coordinated entry approach and who gets left behind when we systematize things. And thank you, Andrew, for highlighting another important key is the engagement and outreach component of this. And really, for me and the work that my experiences in the field, it's that transition towards the housing first approach and the model itself that really has made such a big impact on providing housing to individuals who are living unhoused. Another really great question that came in through the Q&A was on your thoughts on the distinction between scattered site versus single site housing models, and especially in relationship to the ongoing motel conversions that some communities are working towards. Do you have experiences to touch on? I know, Andrew, you've shared you primarily work in scattered site and in your work. Do you have experiences, any of you all, Emma as well, in working with communities that may have single site housing models, and where some of those differences and distinctions and similarities might be?
I can start, and I think Andrew's model of scatter sites is probably a model in the country. A lot of programs that do scatter site do not have the richness of supports, and so I'm going to start by saying, if you ask me, because I'm very influenced by the way we've done it in San Francisco, we have an incredible stock of permanent supported housing that we fought for, the community fought for, and therefore a lot of our sites are sites, and that includes new housing, but primarily old single residency occupancy hotels. So I think it's very important, and I'll touch the motel issue in a second. Very important to know that in places where we have built an incredible stock, I will call, of supported housing for extremely low income people, we prefer that model in the sense that it allows you to really build community. It allows you hopefully to have a really strong interaction between the property management and the support team. It's not always happens, but that is the goal. It allows you to also have, more constant connection with the residents in the buildings. For those that are in SRO hotels, and we were talking about coordinated entry, at times people don't want to move. And I know that in this call, there's a lot of people that are coming from residential treatment, and whether it's true for people who are trying to stay clean and sober, whether it's true for people, who are from vulnerable populations, elders. I have placed elder Latinas and elder Black women. It's like, what am I going to do in that hotel? I'm going to go crazy. So the placement in SROs is also complicated. And I think as we have moved into this model of motels, which is similar to the SROs, but may have even less infrastructure, what we noticed when we were helping with we actually put 2,400 people in motels in San Francisco during the epidemic. And we jumped with the Department of Public Health to help, in particular, to bring the overdose prevention, because people were dying like flies, was to really recognize that in motels, without the adequate support, similar to what Andrew does in scatter sites, it's very dangerous to put people who use drugs without that support. Having said that, scatter sites give a lot of, as Andrew says, opportunities to get people to really have a much more diverse areas where they can live compared to single sites in particular communities. In San Francisco is usually in the Tenderloin, the most poor communities. That's exactly what the stock is. But with scatter sites, you have to be very mindful, or motels. What are the resources you're going to bring to make sure that people feel safe? Is the staff trained? A lot of the times they bring new teams that have never done housing. That happened in San Francisco. So we had to do this incredible training on housing, on harm reduction, on overdose prevention to make sure that people were not dying. So I just want to say that's sort of like my 2 cents on our experience in San Francisco. Andrew?
Yeah, we don't have the experience with congregate single site housing. You know, at best we'll have a row home with 3 apartments, and we have 2 of those apartments for our participants. Or in a really big apartment complex, per the model, we never rent more than 20% of the units in that building, lest it start to seem like that's the building, you know, where that program is, right? Because we want our folks to feel just a part of the community as everybody else. I think there are obviously benefits to having congregate sites. There's challenges for both. In scattered sites, certainly our staff are mobile, right? They're out in the community all the time. Not all of our participants have a phone. Sometimes we show up for a home visit. We have something really important we need to do, and the person's just not there, right? And then they don't have a phone. It's not easy for them to be found, right? So traveling all over the city. Philadelphia is a decent size, right? If you have a visit in the Northeast and then something later that noon in the Southwest, depending on traffic, it could take you an hour and a half to get from one place to the other. So, you know, the resources and the amount of staffing that it takes to go see all of our 550 participants scattered throughout the city. You know, we have, you know, about 125 folks working at Pathways now, and our staff that are out there doing those home visits and community visits are busy all day long.
You guys are fantastic. I just want to add that we have created policies for SIP hotels for overdose prevention, and I can share in the chat before we end. And that was the contribution that we did with the San Francisco AIDS Foundation, so that we assure that as many as places as possible. But we had sites where, when, you know, and COVID had a big, you know, COVID and the isolation, these were people that were living in encampments, so they were living with one another. All of a sudden we're put in a motel. We had serious crisis in some of the sites, and I'm talking serious amount of death, until we really start ramping up. And so I will say that's the move in Massachusetts. It might be better to start early with having the whole overdose prevention protocol and any other protocols. We are about to open with DISH, the same partners I talked to, the Panoramic, 2 blocks away from here. It's going to be a program for formerly unhoused singles and adult and families. And we are from the beginning bringing peer specialists, doing the overdose training early on as soon as we open, so we don't get into the same challenges we faced during COVID by the opening of these motels that was too fast, without preparation, and resulted in deaths that were unnecessary. So,
yeah, I mean, I think the only examples I could add, you know, because I think Laura and Andrew's experience is much deeper, but from my capacity building experience is working with a program in New York that were really committed to, I spoke about them earlier, really committed to kind of, they felt like they were using the term housing first, but it wasn't fully integrated and systematized into the way that they were working. So, you know, we supported them to kind of assess that and begin to look at it. And similar to Laura's example, they went down the route of not just partnering with the local harm reduction program to get naloxone. They actually became their own, in New York, they're called OOPS, opioid overdose prevention programs. And there's many community-based organizations that do it, but not as many housing providers, but they worked with the state health department to get registered. They luckily had a registered nurse that was on staff that could help them you know, be kind of available to support that programming. But similar to the kind of what Laura described is that they, you know, it was not just the staff, but also getting the participants on board with becoming this overdose prevention program. And then through COVID, still experienced an elevation of overdoses because of just what people were experiencing in the time of COVID and the level of trauma and what was happening in New York City at the time. I mean, I'm a resident here, and, you know, it was just a very kind of scary time in those initial weeks, but they still saw an elevation in 2020 of overdoses. So it's really kind of made them kind of even think further about, like, how do we begin to systematize this for all of our staff, which kind of what Lara was saying, and both Andrews resonated with me, is like, from the beginning, how are we onboarding our staff in this stuff? How are we systematizing harm reduction through everything that we do? You know, but then they also gave me, they just opened a special single site, you know, congregate housing for young LGBTQ plus folks in the city who, you know, we have a lot of young folks that come to New York because they have to leave wherever they were for safety reasons and then end up unhoused in New York City. So they opened this new housing site, and they were telling me one of the things they did in terms of harm reduction was acknowledging that young people on a Friday want to go out, they want to party, and they actually have a Friday night meal where all the young people come and eat before they go out as a harm reduction measure. You know, so that was a really sweet story that they shared about, like, some of the successes of how they're trying to systematize this stuff even further. So yeah, those are some additional things that I would add to that.
Wow, thank you for sharing that. What a beautiful technique and cool community building opportunity as well. And thank you, Andrew and Laura, for touching on some of the unique challenges and opportunities to both scattered site as well as single site models. I think if I can just add to this already really thorough discussion on the topic, just having a community that can provide choice. Some people, one might work better for them over another. And so in Buffalo, we were able to provide a person with choice of what their housing looked like. And that makes a big difference in their housing experience.
I'm glad you bring in that, Sarah, because having worked with Black and Brown folks in the Mission District in San Francisco, where they were born and raised, where they wanted to be, and shipping them not just across San Francisco. At some point, we were doing scattered housing in 2 hours away from San Francisco. This was disrupting people's abilities to stay in family, in culture, and community. We were shipping families 2.5 hours away to communities that were very racist and didn't have support systems. So I want to say that housing choice, of course, an ideal. I'm glad you could do that in Buffalo and San Francisco. I don't think we can do that. But
different cities.
It's very important to be mindful that when people are resistant, this idea of resistance to housing has a lot to do about the housing that we're building, the systems and supports we're creating. Where are we doing that housing? All of that matters. And so when we see also a lot of folks that say, I don't want housing, it's not that they don't want, in 35 years, I may have met 5 people who may have said to me, I don't want housing, I'm okay living outdoors. Or people who have got sick and tired of waiting and decided, you know what, this is safer than going indoors. But the majority of people want housing. It's just that we need to do more than we're doing so that those options exist. So we're not disrupting communities and culture. Gentrification is about destroying the fabric of our communities. I call it ethnic cleansing, whether or not, I know it's not a very pretty term, but it's real. And so housing choice has a lot to do with that. So as much as we can do that, we fought in the Mission for land that the city owned. And this is 5 years ago, we organized, and now 5 sites were open in the Mission District that are for our communities. And so it took a lot of effort, but it's worth it.
I feel like I also really wanted to jump in because I haven't said too much about like our community inclusion efforts. So in a scattered site model, right, recognizing when folks are coming from living in an encampment, right, living amongst community, having folks that they're interdependent on, right, and rely on for that support and for friendship, right, moving somebody from that into their own apartment can be very isolating. And there are a lot of folks who don't want to do that, or do that and then bring all their friends along with them. And then it causes problems with the landlord, right? So making sure that folks understand the work is not over once somebody gets into their apartment. That's when the work starts. It's not just getting a roof over someone's head and, we make sure you go see the doctor and then our work here is done. No, like community inclusion is one of like the 5 key principles of housing first. So it's, our mission at Pathways is providing homes, restoring health, and reclaiming lives. And reclaiming lives is Do you want to reconnect with your faith-based community? Do you want to rekindle relationships with family and friends? Do you want to volunteer? Like, we have in non-COVID times, the most robust community inclusion, like a calendar of events that are happening almost every single day for our participants. And all of those events are things that our participants have identified they want to do. We're not saying, oh, we think people should have a gardening club. We have a gardening club because participants asked for a gardening club. We have cooking classes because participants asked for cooking classes. We have, events that will like donate $7 to get your ticket to this event, and we'll go do something. We'll go to a Phillies game, right? A couple years ago, our participants really wanted to go to a WWE wrestling match, so that's what we did, right? We go to buffets, we go to the movies, but the idea is we're taking folks out into the community with us to show them it's actually quite easy for you to access these things, right? We're not taking them so that we can like bill for those services, and like it's let us show you all of the things that are available to you. We're going to go with you a couple of times until you feel comfortable going to access it on your own, because the idea is like get people into housing, but then get them out of their house to go be a part of their communities and live the same kinds of like robust, full, meaningful lives that all of us live, right? We don't sit in our homes all day and never go out and do anything. We don't want that for our participants either. So showing them the ways to reintegrate into the community after a long period of like, isolation or insulation from the rest of those types of activities.
I think you're on mute.
Just to add to Andrew's examples of the kind of field trips in San Francisco when we started the Bridge Project, which was probably one of the first, as almost parallel to Pathway, first housing first, we built a baseball team. And so we had nurses, staff, and tenants, and we have cheerleaders that we actually did leagues in San Francisco. And that was one of the most, it was called Loaded Bases, just to honor.
Oh my God, I love that so much.
Folks were, transitioning to housing. This was one of the first projects of national significance by HUD. It was called the Bridge Project. And so we had loaded bases, and every 2 weeks there were games, and we went to the games, and we have our folks, the folks that were most challenged by and the folks that were more strong about, that were participating in every possible way. And in every project I have participated, any community programs we created was an added value. And this I'm going to say in housing, my experience with this in particular in San Francisco is like every building, no matter how difficult that building is, has community programs embedded with the tenants. So that is one, I think Andrew's bringing something that is critically important. Whatever we do, we're not building community. It's very difficult for our communities to actually bring forward that idea of what I call, hoping and thriving eventually.
Wow, that's beautiful. And yeah, a sense of community is key. Key to low threshold housing, and also key for happiness and life as well. I'm going to change gears very delicately here, because there have been some questions that have come in through the chat or previous surveys around advocacy for individuals as tenants who may need to be relocated for various reasons, whether it be a landlord filing an eviction, or perhaps I know in Buffalo it sometimes would come up where if a person was living outside and there was an apartment available, sometimes the choice that was presented was this apartment now in a neighborhood where I may not want to be living, or may not, it may not be the right fit for me, versus waiting for a different apartment. And so really the beauty and role of advocating and relocating and fighting evictions in court, and also and really one of the questions that came in was really as a way to reduce and avoid discharging from the housing program. I think we often, as housing providers, forget that we get to stick with people through potential housing instability. And Andrew, you shared some really great statistics with us last week in our chat on successful outcomes after a relocation. And so I just kind of wondered if you all could speak to the advocacy and the support that goes into providing housing tenants within a Housing First program.
I'll jump in and get us started and say that, you know, a lot of concerns we hear from folks is like, Housing First means that you can let people do whatever they want in their apartment and they're never going to face any consequences, right? Or that's what harm reduction in a Housing First setting means. And that's not the case, right? Like certainly people are getting evicted. And in fact, relocation is, you know, kind of often considered a routine part of program operations in a high fidelity Housing First program, right? The idea is that we handle those relocations as quickly and with as little added stress as possible. The relocation rate for folks in their first place can be as high as 20 to 30% of individuals that face an eviction, right, or need to be relocated for one reason or another. That's a decision that is come to between the landlord, the tenant, the clinical team, the housing department, right? It's not a surprise to the participant when this happens. There have already been ongoing conversations about the concerns leading to the possible relocation. And that's facilitated through like very open, regular communication between all parties, right? So what we find is if we have to relocate somebody, the relocation from a second to a third apartment is usually about half that initial rate of 20 to 30%. The goal being help the participant learn from the mistakes made, right? So that they can preserve their next unit, right? And maintain their tenancy more successfully. Folks don't know what it means to be a good tenant if they've never had the opportunity to live on their own, right? So there's no set number of relocations. We don't say it's like 3 strikes and you're out of the program. It's like we look at any disruption to continued tenancy is just like a stressful event, not a termination of services. In any long-term relationship, there are going to be stressful events, and that's how we look at it with our participants, right? So what we do is we kind of like recommit to that support. We actually increase our level of support during those times rather than pulling back. And then we build a lot of trust and rapport with our participants along the way. Certainly we're offering interim shelter if we don't have another apartment that's immediately available. And then if somebody loses an apartment, like they might have fewer choices in moving to their second apartment, right? It's like, well, we don't have another apartment in your first choice neighborhood right now, but we have this apartment. And this is, you know, maybe where you're gonna have to be for the meantime. So yeah. Occasionally, folks will return to a congregate shelter for a short amount of time before their housing becomes available again. But we're working with folks based on what's available to them and trying to incorporate their preferences. But you know, choice doesn't always mean unlimited choice. So we do the best we can under those kinds of conditions.
I'm just gonna add that, of course, in scattered sites, there's more ability to transfer a client from one unit to another. Having worked as support service director of a fixed site, it's a little more complicated unless the organization has several buildings, and it depends on the severity of the situation of that tenant. So I want to say even in the most dire situations we had, for example, of a person that was pretty psychotic and actually started to challenge the property management director and some staff with threats. I'm talking with scary threats. What we did is, and this is what I wanted to mention before we go, you know, we learned from corporation from supportive housing how important it is to understand the property management side and the support service side of supportive housing. And in that regard, we took the different roles really seriously. So the property management was moving forward with trying to see if the person will cure this continuous threats, where our support service team, we had actually a clinician in the side, was actually taking the conversation with the tenant to say, you know, to keep the person safe, because we couldn't evict until we could evict. right? The person is there, and this is something very important to learn about supportive housing and housing first. The person is going to be there until there is enough to evict in serious situations. So what we did is we actually had our licensed social worker work with that person. In fact, the person ended up leaving out of the pressure, out of the fight, that knew that this was mounting up. The person actually left the building, which is kind of like the best, I always say, the best outcome in this circumstance. Did not face an eviction, and we didn't have to face this person ever again. But it's very important to know that that's why the roles are so important, so that the property management continues to do all of the process towards, whether there is, in San Francisco, typically an eviction may result first in a negotiation and then an eviction. So we go through a facilitation process. So it's very important to know sometimes there is no such a thing as moving people around. I do know, though, that for housing providers that have a lot of stock of housing, it might be possible to move a tenant to another unit where either the situation is less chaotic, there is more support, there might be nursing on site. So we have some sites that have nursing or more clinical support. And that brings the issue of support again. For some of our communities, it came out, I think, in one of the questions, with people who have serious mental illness and people that are really impacted by trauma, it's very important that there is clinical support. And in a lot of housing programs, that doesn't get built. But I think that when there is those kind of situations, it's very important. The support service team has to step up to let the property management team do their work of what it takes to figure out if that person is a fit or not. And lastly, I'm going to say, a lot of the times we're placing people in housing, might not be Andrew's situation, in places that are less than adequate for the needs of that particular person. And so that is the challenge. And housing providers sometimes go through trials and tribulations to do whatever it takes to house someone that really needs much more higher level of care. So
I wanted to also add that this is another benefit of master leasing, right? Because the apartments are in our name, Pathways to Housing PA, someone's voucher isn't tied to a specific unit, so we can relocate folks much more easily. Whereas I work with folks in other states or other counties who say, all right, well, that person lost their voucher, they lost that unit, so we have to apply for another voucher to get them into another unit. Whereas it's just much more nimble and flexible. And as such, we also have folks on staff at Pathways who are credentialed to conduct a unit inspection, like a licensing inspection to make sure the unit is habitable. So we're making sure that our participants are not moving into substandard housing that can't meet, somebody's basic needs.
And last but not least, I want to say the buildings itself might be, I remember when I started this work, I went to the first harm reduction or second conference. There were people from Vancouver talking about building buildings that were resistant to people who use meth and were pulling apart things from their rooms, which happens. But I think it's very important that from a property management perspective, it's also important to know what is the limit? How many times can I change that toilet that my person removed because it was very paranoid that there was going to be someone spying from the toilet? How many times do we cover the whatever, we need to have some AC in the room, but the person is really paranoid about what's happening on the other side. So we have some amazing providers that are able to put some funding to cure some of those building issues. And then at some point, you have to make decisions. No matter what I do and I modify, it's still impacting this person who has severe paranoia, and this building may not be the best building. But I think those are the real things we didn't talk enough to say. Sometimes the impact of both trauma, mental illness, and some of the substance use can really be challenging in housing situations. So that's what I reiterate what Andrew is saying. That's why we believe in supportive housing, because of the first piece, the support piece. We also want to make sure that property management and housing programs, especially new housing programs, really work very closely with the support services and vice versa to make it a very successful experience for tenants and everyone.
Yeah, I appreciate the emphasis on supporting the person as well as the property managers and kind of understanding that there's roles here, and that housing programs. We're advocates for our tenants first and foremost, and other people have different roles to play. But no one should be left alone in these difficult conversations that happen when you work in the housing field. So unfortunately, we do only have time for one more question. And there have been several questions that we didn't have time to get to today, but they are all recorded. I have a list of the ones that have come in, and we will incorporate them into future learning communities. And we appreciate everyone who's asked questions and everyone who's really wrestling with these strategies to provide low threshold housing to individuals living unhoused. And so for one final question to you all, if folks are interested in learning more about harm reduction and housing first, are there resources that you would like to share? I see Laura just plugged Corporation for Supportive Housing. They're my favorite. Or is there anything else you'd like to share with us in the time that we have left here? So resources or just any other final thoughts?
Since I know that Andrew has a university, I'm going to let him go last and really explain all of that. I put Corporation for Supportive Housing because they were my first trainers, and some of you may know Joy Rocker. She was one of my first mentors. So I would say Corporation for Supportive Housing is a great place to go to learn about sort of like these roles. I also want to say Housing First, even though it was developed in the community, it became adopted by the National Alliance to End Homelessness and the Interagency Council on Homelessness. So I'm putting here some of the Housing First that comes from the National Alliance. And then I will share some before we go, and I let Andrew talk. We're building our capacity of the National Harm Reduction Coalition to also have a robust sort of set of policies and trainings around housing and harm reduction. So I'll share our link in a second. Andrew?
Yeah, well, when folks ask me for harm reduction resources, I always point them in the direction of the National Harm Reduction Coalition. Obviously, excited about the conference later this fall in October in San Juan. And then Housing First Partners Conference is actually happening next week in Seattle, Washington. So if any folks are traveling to that, there's going to be fantastic conversations going on there. And then the National Alliance to End Homelessness does its Solutions for Individual Homeless Adults conference that happens in Oakland. And that's always a fantastic resource for conversations around Housing First and harm reduction. And so shameless plug, obviously, Housing First University is what I do with my time. So we offer custom training, technical assistance, and consulting to community groups, nonprofit agencies, governmental bodies, community organizations, whoever's interested, right, on the Housing First model, harm reduction, integrated care, service delivery best practices. We're accredited through the Association of Social Work Boards approved a continuing education program. So we also offer monthly webinars on, any of those topics under those various subheadings that can get folks CE credit. We do, giant kind of systems change packages for organizations moving towards a Housing First model. So would be very happy to talk with anybody about any of that. And you can find us at housingfirstuniversity.org.
Emma, do you have any final thoughts or resources that haven't been touched on quite yet?
No, I don't have anything to add. And I did see somebody's request in the chat about learning about more local options in Massachusetts. So I think that's definitely a conversation we'll take back to the team that have been putting together these sessions to look at how to offer some follow-up information, or maybe even a follow-up session that's more kind of locally focused. So thank you for putting that in the chat, that request. Yeah, so I don't have anything else to add, but to say thank you for involving us in this series, and a special thank you to Laura and Andrew and Sarah for collaborating with us on this. It's been a really fun, project to be involved in, and I hope it's really helpful for folks.
I agree. Thank you all, and thanks for sharing so many wonderful insights and directions to take this work in. We will have Craig Regis joining us from the Kraft community I'm for Kraft Community Foundation.
Is the Kraft Center for Community Health. Yeah.
Oh, right. Okay. Yeah, Craig, thank you so much. He'll be closing us out.
Thank you so much. And I just want to echo the thanks to Laura, Andrew, to Emma and Sarah for lending their expertise and having this really incredible and timely conversation. And thanks to all of the participants for being here and for asking really thought-provoking questions. I think it was a really rich conversation. And for those who don't know me, I'm Craig Regis. I'm program manager at the Kraft Center for Community Health at Mass General. And the Kraft Center is an organization within Mass General that's focused on expanding access to high quality healthcare for vulnerable populations. And so we have several different programs, and some focus specifically on serving people living with addiction. And so we've had the pleasure of working with RIZE and the National Harm Reduction Coalition in putting on these events to help to spread best practices and to share ideas and tools so that we can all effectively work toward similar goals and making sure that people living with addiction are served with respect and with the resources that they need. So we hope today's conversation has been helpful in highlighting some effective strategies and tools that you may consider adopting in your own work. As we mentioned previously, and as Sarah was just alluding to, we intend for this to be an ongoing conversation. And so this is the second in our series of harm reduction, housing, and hope. But the next step that many have shown some interest in is shifting the conversation to a bit of more of a local implementation viewpoint. So we can kind of take what we've learned in these previous housing and harm reduction discussions and think about, what strategies would work locally in Massachusetts, and to identify not just strategies, but also potential challenges, and hope to foster some cross-sector collaborations to ensure that we're all working together in the best possible way with complementary work that will best serve the community. We also hope to hear some feedback about today's community. So as you exit from Zoom, you'll be prompted to complete a survey, which we'll review and we'll use to inform future events. And because we want to make sure the content remains both relevant and helpful. Also, please don't hesitate to reach out to staff at the Kraft Center or RIZE or the National Harm Reduction Coalition if you do have any additional thoughts or questions. Our goal is to provide opportunities to learn about best practices as well as foster relationship building across diverse stakeholders. So obviously these are issues that will not be solved overnight, but we have confidence that we're all aligned in our goals. And so we look forward to continuing this conversation to how to best support people living with addiction with supportive housing. And we'll look forward to working with you over our next couple sessions. Please stay tuned for upcoming news on future events and future resources. And thanks just again for attending today's webinar. It was taped, so for those who may not have been able to stick around, or for those who may have not been able to attend at all, we'll make sure to distribute the link so that everyone can have access to these important resources, and we'll look forward to staying in touch. So thanks again. It was great having you all on, and we'll look forward to continuing this conversation. Take care, everyone.